Thank you, Madam Chair and committee members. I appear today not only as a witness, but as one who has borne witness to good early progress that's been made coast to coast to coast at the community level with federal leadership. And reference to this work is made in the aforementioned CHPCA brief to the committee. However, I wish to acknowledge the role of 1995's of Life and Death and the 2000 update of life and death reports as important Senate work, which has actually informed and guided several programmatic innovations throughout the country. And I see there's like a lot of staff people here and the senators proper. I just want to say that there are those of us out there who are looking at that, reading that, understanding that, and saying, as a focal point in a locus, how can we actually do something with it? And we are doing things with it. I also wish to acknowledge the recent federal investment made by the Primary Healthcare Transition Fund in Pallium Project Phase 2, and the issue framing of those two Senate reports in particular, and the catalytic investment in hospice palliative care capacity building through that Health Canada one-time investment from the Primary Healthcare Transition Fund have been essential building blocks in advancing better care of those with progressive chronic illnesses leading to death and the dying. In the context of the special committee's work now, I'll focus this afternoon on the federal role as the fourth area of focus arising out of your Phase 1 work, with a brief emphasis on the issues of housing and transportation, abuse and neglect, health promotion and prevention, and health care needs. And thematically and rhetorically, I pose the question to the committee, where is the active management of decline to assure that Canadians live as well as possible until death, reflected in today's public policy agenda? Clearly, this question is of interest to all Canadians due to the universality and the irreversibility of death as part of the human condition. That is, we're all going to die. What's happened, however, in the last 100 years or so, and certainly you've likely heard this in your proceedings so far, is that we've gone from relatively short lives and short deaths by way of farming or industrial accidents, or infectious diseases such as tuberculosis or polio, and as Dr. Liebrecht mentioned too, much longer lives and much longer deaths with periods of difficult decline in many instances. Now, since 2002 in Canada, we've actually had a national consensus model of hospice palliative care, which suggests that hospice palliative care is appropriate for any patient or family living with or at risk of developing a life-threatening illness due to any diagnosis, with any prognosis, regardless of age and at any time they have unmet expectations or needs and are prepared to accept care. Now, we also have in this country a public policy approach in health which, at sometimes anyway, seems to be underutilized, called population health, which is generally understood as one which seeks to maintain and improve the health status of the entire population and reduce inequalities in the health status between groups and subgroups. So co-locating these general ideas of the active management of decline, population health policy tenets, and this idea that we have this model of hospice palliative care as an approach leads me just to some specific comments within the allotted time, because I think what we've seen already is this is a very broad area and we could spend weeks, months talking about it, presenting on it. I specifically want to talk about two specific areas of the long death, and that's namely medically at-risk driving for those with a progressive chronic illness, as well as health risks for family caregivers, many who are seniors, but who are the adult children of seniors. Perhaps the most surprising and disconcerting issue that emerged from the 72 strategic initiatives that we did within Pallium Project Phase 2 has been the presentation of medically at-risk driving associated with progressive dementias. The emerging reality is that we have older drivers who are driving more and longer into later life, with significantly heightened risk that medical conditions will impair driving. The number of older drivers in Canada will more than double by 2030, with some 25% of those drivers being age 65 or older. Now, Transport Canada has projected that casualty rates of drivers age 65 and over will increase by 200% by the year 2026. And drivers with cognitive impairment have been at the greatest fault for an at-fault crash. Now, taking Ontario, and these are some data put together by colleagues at the University of Alberta, and they have been put together for public policy in Ontario, but they're illustrative, I think, in part because Ontario is certainly our largest province. But taking Ontario, for instance, in 2000, there were some 1.5 million persons approximately over the age 65, and just over 1 million of those persons were licensed to drive in the province. The best estimate of the number of those drivers with cognitive impairment is 138,775, and extrapolating from the best peer-reviewed work to date, by 2028 in Ontario, it's estimated there will be 3.2 million persons over the age of 65, with 2.4 million licensed to drive and nearly 346,000 estimated to have a dementia. Clinicians and provincial driving administrators are currently very poorly equipped to deal with persons and families impacted by cognitively impaired driving associated with progressive dementia in particular. The perception that is that rather than the reality is that patients and families often see the primary care physician as the person who has, quote, taken my license away. Now, why is this important? This is really important because the clinician-patient or the clinician-family care relationship is often interrupted over that driving issue at a time when it's most needed to support that family in it towards the decline in death. And I certainly cannot begin to share with you the number of tragic stories of intractable family conflict around having to take mom or dad's keys away that I have heard in the last 2 years in particular. It seems anywhere I talk about this, people come up after and we are engaged around it. This driving issue is the first major public loss on a journey of progressive decline, and it's also one that's a useful, practical starting point for focusing other policy and programming issues, including profound implications for housing and caregiving in a society built around the passenger motor vehicle. And while I appreciate that the administration of driving is a provincial legislated responsibility, it seems that it makes very little sense to have a Canadian Motor Vehicle Safety Act where increasingly the most unsafe element in the equation may be the driver. So what I want to do is very briefly link to other public safety concerns in hospice palliative care and suggest there's a federal leadership role to work on these things. I expect that you've heard from experts in other reference as well as received briefs about the impact that family caregiving has on the health of the status of family members, and those are also alluded to in the CHPCA brief. I'd like to simply highlight before the committee that these longer periods of decline are played out in homes and communities, and clearly there's an increased risk of elder abuse and neglect, either deliberately or negligently as linked to caregiver burnout. I'd like to recommend continued federal leadership and national approaches to health care provider training in the areas that I've mentioned herein. I think it would also be useful to see, to the extent possible in the current climate, FPT initiatives to address public safety and retirement from driving in a way that can be dignified and just recognize, and that's a heavy emphasis on the just, but to recognize that we are entering an age of retirement from driving. It would also be helpful for the RCMP in their capacity as the major contract policing agency to provinces and territories, to take a leadership role in education and enforcement around the medically at-risk driver in partnership with other agencies. And given that the Canadian Home Care Association is also on this panel, I'd just like to include in my note here that I'd like to extend that recommendation around the RCMP to include better education and support for prescription opioid and drug safety in the home. It's becoming a huge issue both for the palliative care community as well as for the home care community. And if there's questions, I can go on in the Q&A about that. And finally, I guess in light of who's at this panel, I'd like to also suggest the RCMP also has a significant role to provide some leadership at the community level in elder abuse education and enforcement. Clearly, the issues generated by Phase 1 of the committee's work, namely in defining senior and seniors' diversity and the interface with progressive decline leading to death, warrant continued federal leadership in the area of research, including more cross-disciplinary research and better linkages between researchers in life sciences and the humanities and social sciences. And clearly there's a linkage here to what Dr. Liebrecht had to say about that with respect to he's beeping, with the psychosocial agenda. And so I could certainly see opportunities for joint agency initiatives, for example, between the CIHR and the Social Sciences and Humanities Research Council. So in closing, I'd just like to say, again, thank you for the opportunity to come and share these views with you. We're quickly moving beyond a first generation of palliation in this country, which is focused on sort of the end stage, end-of-life care issues, so the last few days, the last few weeks. And increasingly with the introduction of the hospice palliative care model of 2002, there's a second generation of palliation, which is characterized by the long death and progressive decline, which demands federal attention in the context of public health and sustainable public health care delivery. I thank you for your time.
Thank you very much.